here, and the topic is whether it is reliable or not. I want to add two R's with reliable. It is also responsible and revolutionary. So the first disclaimer should be it is not going to replace us, it amplifies us. And when the question arises on whether it is reliable or not, we need to answer these two important questions. For how we can trust AI in patient care, and second, what are the different type of evidences we have with AI. So as we are talking about the word reliable, what does reliable mean in a medicine? So it is about consistency, accuracy, and generalizability. And when we talk about perfection, I think all of us will agree, reliability is not equal to perfection. And that is why in medicine also, we rarely achieves that perfection. It is not mathematics. Here it is not 1 plus 1 equal to always 2. It is 1 plus 1. Could be 100, it could be minus 100 or anything. So our clinical tools must outperform some random chance, human error, and also subjective interpretation. So there is the role of AI, which deliver consistent decision support, achieve high diagnostic or prognostic accuracy, and also it improves the generalizability. So let's talk about certain evidences, and if we want to get some insights from this systematic review meta-analysis on closed-loop insulin system, which clearly tells us when we use AI-based closed-loop system, which enhance the precision and also the convenience of diabetes treatment in terms of HbA1c reduction, improvement in time in range, reduction in time in hypoglycemia, and also addressing the glycemic variability. So with the advent of this AI, we can reduce the nocturnal and severe hypoglycemia, more stable glycemic profile, greater ease of management, and also when we talk about the AI-based closed-loop system, they are now the very much part of our type 1 diabetes management, and in some subset, they are the part of type 2 diabetes management. So they are clinically reliable as per this systematic review meta-analysis and consistently outperform the conventional insulin therapy in terms of glycemic control, safety, and patient satisfaction. Coming to another part, the retinopathy screening with AI. And this was the evidence from India only, where we found that AI in diabetic retinopathy screening, which demonstrate high diagnostic reliability, especially in resource limited setting, and it outperformed the human screeners in both accuracy and speed. So you can see the error rate just, it was with AI, it was around 6.3%, whereas with human graders, it was around 17%. So we can use this module as public health screening. Now, you may agree or not, I don't know, but if I state like this way, 1 out of 3 NSTEMI patient was misdiagnosed in our routine clinical care, and that ultimately lead to their premature death. Whether you will agree or not, it is about one study which had been published in European Heart Journal in 2023, and almost 7,000, more than 7,000 patients were included in this particular study. Now, when we talk about AI and the validation of certain AI-based tools, that actually help us to have a stronger diagnostic performance in NSTEMI. So that is something we need to highlight. We need to use AI in a systematic way. And it is not just we are typing in the chat GPT and we are getting some answers very easily. It is not like that. With that chat GPT, there is lot of insights, and we need to believe them, because they are validated. This is a classical study by which we can have a tongue image and we can predict the diabetes or pre-diabetes. Now this is also another tongue image, whether you can diagnose anyone, but the thing is that this is the clinical image of proliferative verrucous leukoplakia, and ultimately which lead to a squamous cell carcinoma. And we know that India is a hub of having oral malignancies. And very unfortunately, this was a study that 50% of the patient diagnosed at stage 3 or stage 4 of this type of disorders. And one of the very reason behind that, the diagnostic accuracy is not there. So we need to have the help from the AI. And there are the AI tools which are being developed, and they are helping us in predictive analytics, dosing and lifestyle coaching, accuracy in different type of complication screening, and we can enhance the early detection using wearable data. This was the era of digital therapeutics. Now we are talking about digital therapeutics, where we use AI, and lot of digital therapeutics tools are available. And just like drugs, they had been screened through our regulators. This was a classical example. We talked about digital twin. In this particular, the right-sided image, what we can see, it is just like Dasabhuja. AI is just like Dasabhuja. We had worshipped Ma Durga very recently. But with Dasabhuja, we also need to worship Lord Shiva. So Shakti is without Shiva is nothing. Just like Shiva is nothing without Shakti. So we need to have the perfect amalgamation of Shakti and Shiva. And this is few important studies by which we can have AI, the clinical oversight plus AI, which had improved outcome. So due to lack of time, I'm not going in details of these particular studies, but AI had been used with clinicians' synergy, and that drives a personalized and scalable care. Now, very recently, we had witnessed a war, and India won that war. We have a precision. We had done the precision attack, and you can see if we want to buy some good weapon, we need to understand their reliability also. Now, there are certain studies which had shown with this type of AI, we can include a cyber lethal threat also. So just like that, even in the terms of war or weapon, the AI can be used. And that is really concerning too for us. But if it is not reliable, the warmongers will not use this technology for their purpose. Now coming to the population level impact, we need to talk about smarter public health, and for that we need to scale artificial intelligence, especially for the low resource settings. And we need to have definite policy, especially when we talk about the predictive risk maps. So AI is not just for the individual, it is a tool for systemic change. And when we talk about ethical intelligence, we need to build the trust, and for that, now the regulators are ready to screen your AI tools, and that is very important. And in India also we have the DPDP. So the final call should be, when we talk about AI, it is reliable, it has evidences, it is scalable, and now we can call it ethically actionable. So it was previously, when we use stethoscope, sometimes some of our ancestors, they thought it was controversial. So it is time we stop fearing AI and start using it wisely. Thank you very much.
Thank you, sir, for giving an excellent proof to use the AI. And one more. Okay. Our chairperson, Dr. Maulin Shah, is there. So please, I invite him to join the dais. And now, the non-reliability of AI, and for that I invite Dr. Arvinda. He is a chief diabetologist at Dr. Arvinda Diabetes Center, Bangalore, India. And he is one of the few with MRCP London with triple FRCP, Edinburgh, London and Glasgow. He has multiple awards in his credits, and he is an executive committee member of National RSSDI. Over to you, sir.
So good morning, everybody. At the outset, I thank Dr. Banchizabu and team for making me a part of this conference. Tough topic, tough debate, but it's a debate, so let's have fun. I have to justify my stand. So thanks, Bhavesh, for the nice words. How reliable are AI driven outputs? Non-reliable. That is what my stands. So, ladies and gentlemen, we have got more than more than 2,000 digital health apps. I'm sure all of you are seeing mobiles now and then, but how far you are using it correctly, we don't know. So what we know so far, there are so many apps for like artificial intelligence in diabetes management. It's a spoiler, isn't it? You have to see the patient, not the mobile or the internet. You have to see the patient first, give the touch first, then we can talk about it. So there is a time for a dose of AI reality. You can see in this slide what catches your eyes. Yes, Dr. Shambhu has showed diabetic retinopathy, food neuropathy. Yes, we accept. But what remains unseen, because small data, misclassification, poor data quality, insufficient clinical data, imbalancement, many issues are there. So what catches your eye? It's a heavily skewed toward predictive models and clinical decision making. So what remains unseen? Critical areas like health monitoring systems, public health interventions, diagnostic image technologies, 18.6% remain significantly underutilized. So challenges relating to the adoption of AI and data-driven technology for diabetes care, the challenges is data quality control, poor technology design, lack of clinical integration, privacy concern, non-adherence, imperfection of laws and regulation. Dr. Shambhu showed some slides about the latest data about the regulation, but still it is a gray area. It has to be uniformly done across India, across the globe. So if you take AI thrives on clean, structured data. In Europe, 97%, in Netherlands, 87% in UK. But in India, we have got stored Indian medical record, data chaos, not data science. Only 35% of the healthcare facilities have full EHR system. Records are often handwritten and scattered. This is the last year data published in Diabetology. So GPT gave medical advice, scary or smart. So AI GPT can give generic, unsupervised advice, but that's dangerous without a doctor and it is not personalized. In one of the study published this year only, comparative analysis of AI tools for disseminating 88-2025 diabetes care standards, what is the implication for cardiovascular physician? What it came is AI limitation in diabetes management. It meets the 2025 ADA updates, weak evidence referencing, incomplete guideline coverage, requires clinical validation before use. This year data. So another article, systemic review of the barriers to the implementation of artificial intelligence in healthcare. Out of 59 articles were considered to identify the key obstacles. What are the 6 key areas? Ethical, technological, liability, regulatory, workforce, social and patient safety concerns. If you take the ethical barriers, lack of trust, privacy concerns, data ownership and consent, and conflict of interest. Technological barrier, data issues, integration and usability, validation gaps, infrastructure challenges. Liability and regulatory barriers to AI in healthcare, who's liable, legal catch, lack of clear regulation. What are the workforce barriers? Lack of training, physician engagement, job displacement fear. Whatever said and done in corner of our mind, that is always goes on. What this AI is coming, what happens to future, my children is doing, my grandchildren is doing medical, what is this happening, all these things comes to our mind. So patient safety barriers to AI, distributional shift, automation bias, resistance to innovation, need for explainable AI. Social safety barriers to AI adoption, social acceptance, selection bias, healthcare bias, digital health inequality. But here, what get ignored? AI research usually shows us the exciting stuff, high accuracy, smart predictions, better than doctors. But legal barriers, ethical issues, and technical problems. So patient safety, we have to take care. Social inequality, big issue, and most important is the cost and access and the user friendliness. So challenges in execution of AI in India's diabetes management is a wake-up call for clinicians. If you take the geriatric population of across the world, India is the third country with the highest geriatric population. In one of the studies, it shows only 55.6% owned a personal mobile phone. 44% had access and only 35% had internet access. Despite 44% having access to smartphones at home, only 12.8% used phones for health purpose. I'm sure all of us are in the same boat. We have got Apple phone, Android phones, but how much we use it completely, what are the things are there, we don't know. We know only email, WhatsApp, Facebook, Instagram, Reels, and that's it. There are so many things which we don't know, which we don't see, which we don't know. So patient perception on utilization of smartphone health app for self-management of diabetes, only 30% were aware of mHealth apps, only 7.7% use them daily. Major reasons for not using include a lack of awareness, technology glitches, and belief of no need for guidance. So how can, see, this is a practical point. How can AI manage diabetes when many of our elders are still figuring out how to unlock their phones? Forget about technology. See, this is the practical problem. So digitization in Indian healthcare, yes, there is a progress. We are very proud of it. But challenges remain: gaps in digital infrastructure, low digital literacy, and lack of structured training programs on AI tools. So AI needs digitally literal hands, not just smart algorithms. So CGM in diabetes care, yes, we are very proud. Dr. Banshi sir is giving the CGMs to the quiz winners. But in this study, among the 30,000 patients, only 13% had used a CGM. So CGMs are popular in developed countries, but in India, they need to become more affordable to see wider use. So enigma of the doctor-patient relationship, that is very important. A trust-based bond between doctor and patient is an integral part of patient care and can promote recovery, reduce relapse, and improve treatment adherence. This is one of the Mental Health Care Act 2017. So AI in healthcare focuses more on data and documentation. Could this reduce the emotional trust and connection with this act? Aims to protect relationship between doctors and the patient. I'm sure you have seen the Rajinikanth movie. In one of the movies, Robot, using AI tools meant to help, but it lacked emotion. So, but we rely on it too much and ignore the human aspect. It could be like this robot Chitty putting healthcare at risk. I'm sure this is the problem. It's going to happen if the human things are not put properly. So this should not happen, ladies and gentlemen. See that the monkey, what is saying. So it is saying dying in the operating table because my doctor used ChatGPT to pass medical school. Funny now, but let's make sure AI supports medical learning, not replaces it. So summary of these things, you see: precision problem, clumsy integration, privacy nightmares, cultural cluelessness, and legal gray zones. So when it comes to making sense of patient's history, understanding non-verbal clues, building trust, and addressing the subtleties of human suffering, there is no substitute for human touch, and a doctor's role as a healer, counselor, and advocate cannot be outsourced to an algorithms. AI hype and the clinical reality. I'm sure all of you will agree on this. There are so many things, but it is clinical reality we have to be taken care. My opponent Shambhu, it says to me, I got, Dr. Arvind, I got Gemini, ChatGPT, GitHub Copilot, AlphaCode, Synthesia, all those things he's telling. He asked me, Tera paas kya hai, Arvind? So, mere paas to personal touch hai, empathy, sympathy, and experience hai. It's a balanced way forward, Dr. Shambhu. Combine it with a strong doctor-patient relationship and invest in digitalization of records, elderly friendly tech, and patient education. Use AI for what it does the best: data crunching and pattern recognition. Thank you for your patience hearing.
Thank you so much, sir. Very well explained and very beautiful points in favor of non-reliability of AI. And thank you so much. Now I invite Dr. Arvind Gupta for the expert review whether the AI is reliable or non-reliable.
Thank you very much. Before that, Shambhu is there. Can I have a rebuttal and then I'll see. You have 2 minutes.
I think I don't have any rebuttal because whatever I had told, I had emphasized, that had been again retold or re-emphasized by my senior Dr. Aravinda ji. So the thing is that he had mentioned about, or he had asked about the questions about AI use, how we can have the we can say the equitable distribution of AI use. But I think many of us had a thought when there was notebandi, that how we can use the digital transfer of money. But now, even in the core of our villages, they are doing digital payment. So there is no harm in that. So if we think it is not going to replace us, but it is going to help us in a way the stethoscope does, then I think there is not a problem. Our job is to remove the fear inside us that AI is something which is not reliable. Rather, we can accept it along with our own insight, our own touches. Always it is important, because we are human, and we should add another E to human, that we need to become human, and that E is for empathy. And empathy is not a job of AI, it is our job only. But when we talk about reliability, the data matters, and whatever data we had presented, even the recent most systematic review, meta-analysis, and different RCTs, they are strongly supporting the AI's reliability. That is my point.
Thank you,
sir.
Shambhu. Dr. Arvinda, please come here. Shambhu, please sit here. Okay, so before I'll give my comments, not the expert comments, because AI is still in the evolution phase and nobody is expert here. Let me ask all of you, how many of using AI in your day-to-day practice, even for diagnosis and for management? 1, 2, 3, 4, 5. So just see here, this is an evolution phase. The most problem with the AI, Dr. Arvinda, is that, Dr. Shambhu, is that that regulatory authorities are not there. Suppose you are using AI and the output or data or something what you are giving misinterprets and gives you the wrong sorts of results. What you will do? It will be a very deleterious and harmful for your patient's point of view. So regulatory authorities are not there, no regulatory is there, no reliability is there at present. At present, reliability is not there, and actually even if reliability is there, we are not sure that the AI has given the right answer to all of us. So that is the most important point.
So if you take the WhatsApp, when you're listening to the talks, like at least 20% you will be seeing the WhatsApp. In this, there are so many groups, I'm sure 20-25 groups, all of you are member of it. Anything, whatever things is there, you have some doubt, immediately put to ChatGPT, it gives them all the things. And ultimately what happens, yes, certain things are good, but certain things are extremely bad. In one of the things is there, one resident doctor, senior resident doctor in emergency department, posting the ECG of a ventricular fibrillation. So my ECG is like that, I don't know what to do, my ChatGPT is not working, what is this? Instead of saving the patient, instead of giving a DC shock, he is chatting in WhatsApp to get a review. Ultimately, patient died. So this is where the practicality has to, we have to accept.
Anybody who has something, Dr. Rakesh, you want to tell, because you are using so much in this AI. I think some of the people who are using AI.
So both the speakers did their job very well. Myself and Rakesh sir were discussing, the only challenge that we see with overuse of AI is that the doctors are losing their clinical acumen. In addition to empathy with the patient, they are also losing their clinical acumen. Now people, as you said, they rely on ChatGPT only. They can't read ECGs, they can't examine the patient, they don't even, because now you just give the history and the ChatGPT will give you diagnosis also. So that is a risk for the coming generation at least. Our generation has passed and we have learned through our experience. But the next generation, it's really a risky thing because if they start using only ChatGPT for learning, they may not develop the clinical acumen that we want.
Yes,
One of the important aspect, very useful thing is that from your city only, Dr. Om Lakhani, under my mentorship, he has developed one very good software. It was clinically validated from one of the 3 or 4 prestigious hospitals in the country. And what that software he has made, that just give a few clinical aspects and the age, the BMI, the ethnicity, and few biochemical parameters, just feed it that, and we know that in type 2 diabetes there are 6 classification at present, Indian point of view, that from severe insulin resistant to severe insulin deficiency, there are 6 classes. So it is very difficult a person sitting in the rural area that when he is coming, he knows only glimepiride, metformin, which is supplied by the government sector. But he doesn't know that this patient is having severe insulin resistant. So for that point of view, internet is available everywhere in the rural areas, and that software, what they does, give few parameters, and you will find that this patient is suffering from this class of type 2 diabetes, from any of the 6 classification, and software further gives you the idea of which drugs will be useful for that patient. So, I mean, it is up to the doctor to use those drugs, but it gives you the real gist of that patient without having any, doing so much of sophisticated investigations like C-peptide, insulin, and several other things. That gives you the idea of that thing. So, AI is useful from that point of view, is still evaluating phase, but I think, and like twin studies, Dr. Shambhu and Dr. Shashank Joshi have published very nicely 1-year results, and that has shown a very good sort of remission of diabetes by just using the AI and the different drugs, and the patient himself knows regarding that whether I am having the HbA1c controlling or not during the therapy. So,
sir, it should be safe and smart use of AI, because in our early days, I'm sure all of us, when we are studying our MD and all, MRCP and all, if anybody, any of our professor asked us to give some topics, we used to come home, read Harrison, Davidson, all this Brownwald and all, we used to study so that we get a proper knowledge. Now what is happening is immediately give a topic, see the ChatGPT, get the answer, tell it and forget it. People are forgetting. Ultimately, it leads to cerebral atrophy. So the brain is not working. Cerebral, read, forget. When patient comes, what to do? Very Shambhu, I should ask Shambhu, very Shambhu. People will be looking for Dr. Shambhu.
yeah.
This is true. May I have it? This is true. I am not talking against that, because AI, always there is a chance of cognitive offloading, and that cognitive offloading ultimately make our brain as a new appendix. But the thing is that the question arises on AI and its reliability. So whether it is reliable or not, yes, it is reliable, the data is suggesting, but we also make ourselves reliable. So our entire education system need to be changed, need to be developed, need to be modified, because I think maybe 30 years, 40 years back, when a MBBS student appears for medicine examination, they need to tell which type of murmur it was. Is it a mid-diastolic or it is a systolic murmur? Just check nowadays the MBBS students, whether they can tell us about the murmur.
They don't know about murmurs only.
So the thing is that, so that is what our medical education system need to evolve, and whatever necessary for the patient, that we need to think. But AI is reliable or not, I think all of us will agree that it is reliable, but we need to make ourselves reliable too. That is our job.
Anyway, thank you.